The one area I'm actually really careful, and this is a great sort of clinical pearl red flag, is anytime you put a patient on a probiotic and they get worse, please believe them. And that's really a red flag for SIBO, or the overgrowth of bacteria in the small intestine. Because sometimes when we get the bacteria to the small intestine and it doesn't migrate down where it's supposed to be, now we get the production of methane and hydrogen gas as a result of a carbohydrate or sugar intake, and we actually make the patient worse, right? So if we're dealing with a potential SIBO, a lot of times, even if they're deficient in the commensals in the large intestine, I will hold off until we fix all the other components, then go at them with the probiotic.
Hello, and welcome back to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. So today I had the fantastic opportunity to actually interview a friend and colleague, Dr. Cindy Howard. Cindy's a fantastic human. She lives in Chicago. She has a very big practice there, doing some amazing work. And here is a bio on Cindy. So she is a board-certified chiropractic internist and a nutritionist in a private practice in Chicago and holds licenses in the state of Florida. She speaks nationally, presenting on topics including pre- and post-concussive nutrition, neuroadrenal dysfunction and infection in sport, male and female pelvic disorders, pediatrics, immunology, GI disorders, endocrinology, nutritional blood analysis, interpretation, and genetics. She's also the owner of DC Consulting and Advanced Education Assisting Private Practices. She loves to help doctors to improve their communication with patients, increase compliance, and build a better functional medicine or nutritional practice. She also serves as a Illinois delegate to the American Chiropractic Society. She speaks all over the country on her own personal story with her journey through Hodgkin's lymphoma, and she has a book specifically about this called Positively Altered as well. So I've known Cindy now for a couple of years, and she's just a fantastic human. She's doing some amazing work in her own clinical practice with education, speaking about her book and her own story as well. So in this particular podcast, we had a lot of fun. We spoke about the definition of a chiropractic internist. I never heard of these growing up as the son of a chiropractor, but they're actually much more out there than we realize. These are kind of the tried and true, the down in the actual weeds of being a primary care doctor. So this is pretty amazing work that Cindy's been doing. So we spoke about what is a chiropractic nutritionist. Then we spoke about some of the things that Cindy's practice is really good at treating, even potentially putting in remission, like autoimmune disorders, for example. So we also talked about sexual health in the sense of pelvic floor disorders and pelvic disorders in both men and women as well. Then we talked about supplementation. We talked about synthetics versus bioidenticals. We talked about various types of probiotics, and we talked about poop and how very hard it is to actually supplement people using an empiric strategy, especially when you're talking about GI supplementation. We talked about an empiric strategy for supplementation. We talked about lab-directed strategies for supplementation, which is what Cindy prefers and what I prefer as well. And then, in the end of our podcast, we spoke a lot about her story, which is her story being involved in a clinical practice, her own practice, having young kids, and being diagnosed with Hodgkin's lymphoma, and deciding to go the conventional route with chemotherapy as opposed to going to Germany and leaving everything behind and going the alternative route, which is very, very difficult for her. She's got a very great story there and how she was able to navigate the system and come out, as amazing as she is today. So Cindy's a fantastic human. This podcast was so much fun to record with her. I really hope you enjoy it. If you do, please don't forget to like and subscribe below so you never miss an episode. Enjoy this episode with Dr. Cindy Howard. Dr. Cindy.
Dr. Scott.
How are you?
I'm fantastic. How are you?
What's funny is that, so for people listening, that I just recorded a podcast on Dr. Cindy's new podcast, and now we're doing this kind of like back to back, which is the first time actually I've done this, which is kind of fun. So thanks for sticking with me and now being a guest after having to suffer through interviewing me. I apologize.
No, my God. It was fun. It was perfect. And hopefully this one will be very different so everybody can listen to both and get new information.
Oh, yeah. This is going to be very different because I'm going to be interviewing you mostly. And I have a lot of respect for what you've done and what you continue to do in the world of chiropractic, in the world of just medicine in general. And then, of course, your story and your challenges and your adventures throughout the medical system are very important for people to learn about and to know more about. But the first question I want to ask you is that, my dad's a chiropractor. He's been a chiropractor for 45 years. I had never heard of this thing called a chiropractic internist. So if you can give me a little bit of a background, like what the hell is a chiropractic internist and how did you get involved in being a chiropractic internist?
Well, depending on what websites and Facebook pages you follow, people are going to tell you that it's a MD wannabe or a metapractor.
What's the metapractor?
Metapractor, yeah.
Okay, I haven't heard that. Okay.
And neither of those are really affectionate or good terms, quite frankly. But in all honesty, and joking aside with that, because it's hard to insult me with some of the terms that are thrown out. In chiropractic medicine, when we go to school, most people think about we treat neck and back pain.
Right.
And it's really more than that, right? It's looking at the entire human body, the muscles, joints, bones, ligaments, tendons, cartilage, etc. But really the chemistry, the metabolism side, the diet, nutrition side, the cardiovascular side, right? And the list goes on. So in chiropractic, when you go to school, it's a little bit different than medical school in terms of you pick a school based on the philosophy or what it is you want to learn. It's really not the same across the country. And where I went to school, it was very primary care based. And it's interesting. So I'm going to tell you a little story to answer your question. When I went to chiropractic school, and I went there because I couldn't get into physical therapy school, I actually got rejected. It was very competitive. I don't have good grade. Never did, never will. Not a great academic student from that regard. Can tell you a lot, can't pass a test with, A pluses.
Gotcha.
And because I got rejected, somebody said, well, why don't you just go to chiropractic school and tell the physical therapists what to do? And I love to tell people what to do. Now, things have morphed and the physical therapists don't really need me to tell them what to do anymore, but this goes back 25 years. So I went to school and I went to a school called National. It was National Chiropractic at the time. It's now National University of Health Sciences, and they're very primary care based. And when I sat in the class going, I want to be a sports chiro and I want to take care of athletes and I want to work on their neck and back. And my, as it turns out, mentor was teaching obstetrics and gynecology. And I went, what does the vagina and the penis have to do with chiropractic? And realized it has everything to do with primary care, and did a complete flip and went, you know what, I still love athletes and I still do take care of athletes, but I love this primary care route. So within chiropractic, we also have diplomates or specialties just like medical practices, right? You're a pulmonologist, you're an immunologist, you're a pediatrician. We have similar types of avenues, and one of them is internal med. So I did my postgraduate work in internal medicine, so I get to call myself a chiropractic internist. And then I got bored, so then I went the nutrition route, and I get to call myself a chiropractic nutritionist. And some people out there still call me a wannabe medical doctor, and that's okay, because I just do what I do, and I love it, and it really doesn't matter what my letters or my name is. What really matters is we take really good care of people and they get well.
Yeah, I love that. I mean, so when I grew up, of course, like there really wasn't it didn't seem like there was a capacity really for chiropractors to have these avenues to be able to do these kinds of work. But now, I mean, it's the big thing, right? Chiropractors are coming out, they're doing a lot of, spinal work still, but they're working on these kinds of clinical practices where they're bringing in laboratory testing and doing these kinds of analysis. When you started your practice, did you have anybody to look at and saying, this is how you do this? Or did you actually just kind of figure it out as you went?
No, I had some great mentors. So there's actually a postgraduate program. It's the letters behind my name are DAPC, Diplomate of the American Board of Chiropractic Internists. So it's a 300-hour program. I actually started it in school. And the same professor mentor who taught OBGYN was involved in that organization. And he taught male and female pelvic disorders, which I'm now proud to say I teach, that he's no longer with us. And I've been doing that for, 15 years or so. And it was just interesting because there was so much to this that I didn't understand or didn't know, that having that mentor really opened my eyes. Now, I hung the shingle. So where a lot of people graduate from school and they work for somebody, I told you I like to tell people what to do, which means I don't like being told what to do. So the idea of working for somebody was not on my radar. So I hung the shingle, as they say, and my very first patient was a woman. She was actually in the military, and then it was a police officer, actually sheriff, I believe, who remembers 25 years ago, right? It was a long time ago. But she came in with what was just textbook of a hot disc, a disc herniation. I could finish her sentences because I just got out of school, so I knew what the answers were, where it would radiate, what dermatome pattern it would follow, what she was feeling. And I thought to myself, this is going to be so boring if I have to do this for 25 years. And please don't misunderstand. I think there's chiros out there that are doing amazing spinal work that love a herniated disc and are brilliant at it. But I get bored pretty easily, and I need just to be jazzed with some new things. So I decided when she came in to run blood work on her, because I was taught how to run a full blood panel. And looking at her from a chemistry metabolic standpoint to realize that if I could help lower inflammation, if I could help affect the nerves, if I could do some of those things on a chemical side, besides just the manual techniques that I learned, could I actually get her better faster? And from that moment on, I believed we could. And so was born the internal medicine side of my practice. And the joke is if you sprain a toe, I'm running lab work on you.
So that's your framework, really. So no matter who comes through the door, like how do you, like when you see somebody coming in, whether it's an acute issue or more of like a chronic issue, do you have the same basic framework that you use as far as laboratory analysis? Or obviously it's going to be very, very personalized, but like how is your practice run now where you see, I know you see like you don't have a huge list of patients anymore. I think you're pretty closed at this point, but do you have do you try to specialize in one particular type of group of people, or do you kind of see everybody that comes in and just kind of keep it small?
Yeah, I guess I'm going to answer that both ways. I mean, there's nothing that I won't treat in terms of condition, symptom, disease.
Yeah.
I'm pretty open that way where I love the idea, even if you bring me something that I'm not familiar with, because, we're a detective, right? We solve a puzzle, and that's fun for me to figure out what's going on, even if it's something I'm not super familiar with.
Sure.
And we're good at that in the office. At the same time, it's a pretty low volume practice because I spend a lot of time with patients. It's not a 5-minute visit. It's really understanding their history, their background, and even more importantly, sometimes their needs. What are they trying to accomplish in their health that I can assist with? And I hate this term one size fits all. It's a one size fits all that becomes individualized to meet your needs. Meaning, lab tests are lab tests, right?
Right. Yeah.
I can't recreate the CBC and the CMP. They are what they are. But what I can do is take the results and couple that back with the history and the presenting symptoms and the needs that they're trying to accomplish, and then figure out what do we do with that information that's very specific to that patient, so it's not a textbook program.
Gotcha. So what would you say is like some of the, like your bread and butter as far as like certain cases that you find that like you can treat better than nobody else can because of your, or very few people can because of your framework? I mean, I would imagine there's a decent amount of people that come to you after getting failed by the medical system in various ways. What's kind of like a home run for you? Like, or what's close to a home run for you when people come in like with like a certain type of condition or disorder and you're like, oh, we got this like 95% of the time, that kind of thing.
Autoimmune disease, hands down.
Okay, so let's dig into that. So how do you approach somebody with an autoimmune condition?
Autoimmune is really fun because I think we get it wrong most of the time in the medical space, right? We get it wrong because we're giving a label: rheumatoid arthritis, Hashimoto's thyroiditis, lupus, pick something, right? Diabetes, cancer. I mean, they're all versions of autoimmune disease. And then what we do is we have a treatment, usually a drug, not always, but a treatment, and here you go. And we hope that that fixes the problem. And then congratulations, maybe if it does. Or more likely, it's congratulations on your autoimmune disease. Based on the literature, we don't ever cure that. And we hope to just get you feeling as good as we possibly can, knowing you're going to be on a roller coaster for the rest of your life.
And taking drugs for the rest of your life, yes.
Correct.
Yeah.
And that's where I love that condition or conditions, if you will, because the name of it doesn't matter to me, right? What the body is actually attacking to give you that autoimmune disease is kind of irrelevant. I want to know what got you there, the why, right? So it's not the what of the disease, it's the why your body went bad that started to attack something that it shouldn't. And when we backtrack out of that, and sometimes that's hard. I mean, there's a lot of different aspects that can trigger the immune system to malfunction.
Sure.
That's fun because now we fix the actual thing that broke. And I probably shouldn't say this out loud because now it's recorded, but in a court of law, I will never tell you that we cure an autoimmune disease because I don't have the literature to back up what I've said.
Yeah.
But I do have the clinical experience to show you where a patient walks in with a disease with the labs to support the disease. And now for years, if not decades, if they were to start over with a doctor, there is no sign of that disease. So did we maybe cure something? Or at least get it so under control that nobody knows they have it?
Or whatever
And at the end of the day, who cares as long as they feel amazing and there's no signs of the process?
Yeah, I was talking to somebody actually at this recent conference we were just at. He had ankylosing spondylitis that was diagnosed in the 1980s, and he read a nutrition book and he cured himself, is what he said. He said no longer have any symptoms, and so I think that it's such a fantastic perspective to say that like there is something that you can do, right? And so I'm a lot of these patients that they go to the medical system, they get on disease modifying drugs, they have terrible side effects as a result of this. Have you found to be like there's certain more challenging autoimmune conditions versus others? I would imagine something like lupus or rheumatoid arthritis may be harder than like certain other ones, or is it usually Does it depend on the person specifically, would you say?
Both. And yes, there are some that are more challenging, but it does depend on the person. And there's so many factors that go into that. One, how chronic is it? Two, how many components are leading to the chronicity of that pain? Three, patient adherence. Are they actually going to do what I tell them to do?
Yeah.
Mindset. Are they in the game of the belief system that we actually can facilitate change enough that it doesn't exist? Or did they follow that doom and gloom of like, I'm stuck forever. I just hope to maybe get out of bed a little better?
Yeah. The disease mindset. Yeah. Yeah.
Absolutely. And I think we fail. I think we fail in medicine overall a lot of times. And hope is a very scary word for me. I don't know that I like the word hope, but I do actually believe that just as the body went bad, the body can go good. And sometimes we don't win and sometimes we die. But that belief system of never giving up and always trying to figure out the why something is going on to facilitate the change until that very last breath, I think is really important. And in medicine, a lot of times we're not given that opportunity to work that way.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our gut immune system module. If you want to learn about from your mouth to your anus and everything in between, this is the module for you if you're a clinician. How to optimize the gut microbiota, how to understand this in a real in-depth way. Go to homehope.org, save 10% on this module or any module of our certification course using code podcast10 at checkout. Now back to the show. Yeah, the why is just, it's not that interesting oftentimes, right? It's like, because also the why it opens up this whole like kind of can of, Pandora's box or a can of worms or whatever, because then you have to actually discover this in your patients. And like in a conventional medical model, you have 6 minutes or 15 minutes to work with somebody to discover that. This is not possible, right? So this is probably why, I would imagine your intakes are very, very long and your first couple of visits are very, very long, just to kind of discover what's under the hood when it comes down to what might be happening.
Yeah. And what's amazing is my intakes are as long as they need to be. And I think that's the difference too, right? Is when, you work for a corporation and you're told you have 6 minutes to move on to the next patient, you better ask some really good questions to get 6 minutes worth of material. In my office, some cases are super simple and really the intake could be 15, 20 minutes and sometimes they're hours because everybody's got things we've got to dig into to find that. And I think it's that aha moment of, that one thing that they said that they didn't think was important that changes the entire outcome of their health. And if you don't spend time with people, you don't find that.
I'm 100% with you. I've been involved in hyperbaric medicine for a long time, as you know, and I've worked with a lot of autoimmune conditions over that time. And I see a lot of benefit actually for going in the chambers, but it's not going to reverse their disease process. It's going to mitigate it. It can help keep symptoms at bay. But I always tell patients, this is not, your symptoms are going to come back after hyperbaric therapy if you don't continue with hyperbaric therapy over the long term, which is expensive and it's a lot of work. Why don't you work with somebody like Cindy that can actually work on the ground here and truly see that shift in remission kinds of status, which is certainly possible. So the other topic I wanted to talk to you about, because this is going to be, we always have fun, is you were talking about being a specialist in male and female pelvic disorders, right? And I wanted to talk about this with sort of in the realm of, I know you're very much involved in sort of sexual health optimization and sexual function. Like, how is this part of your practice, and what are the kind of main kind of areas here that you feel like are missing from the conversation that you have like a lot of interest in and that you're working on?
Yeah, it's interesting. Just a little background on how this became so important to me. Besides taking over the class to teach male and female pelvic disorders, I was teaching one time and we were discussing some cases, and I had a doctor who wanted to discuss a case in his practice. And he says to me as he's talking, he goes, you know how when you dribble down a basketball court and you go to make a layup and sometimes you make the layup and sometimes you don't? And usually what I think comes out of my face at this. So after my strange look back to him, I said, did you seriously just describe a sexual interaction and reaching orgasm as a basketball game and making a layup? And I probably embarrassed him pretty good. And I have no regrets doing that because I thought, here's a doctor, like he's not even using the right words, right, with patients. So how are patients going to be comfortable if they have to talk about a basketball game in order to say, I'm having trouble reaching an orgasm or climax, so I didn't make the layup? And that's where this birth of, I have to, you get this mission, right? Like I have to go out and educate people on using the right words and having the conversations and asking the questions, because we just don't do it. And when I'm out there there's tons of stuff on hormones, right? There's a seminar every day. You can go on the web and learn about your hormones and what's dysfunctional, how to treat it. But what we forget is sexual health is more than just hormones, right? There's a mental component, a physical component. There could be vaginal infections. There could be sexually transmitted diseases. There could be trouble with performance. There could be trouble with technique. There could be, I fell off the swing and hurt my back. True story in my practice.
What kind of swing?
Yeah. Because you have to ask the mechanism of action for your low back pain.
Sure. Yeah. Interesting.
And she was willing to tell me that she fell off the swing that they have in the bedroom. There's the couples that think that they can't or shouldn't engage in intercourse anymore because erections are difficult and vaginal dryness exists and they're already 70, so they shouldn't be having sex. And I think we should have sex till we're dead if you want to and you have a great partner. And all of these things, gender changes, sexual abuse, right? We're afraid to look at patients and just ask those questions because we feel like we're being invasive. And yet, as physicians, isn't that what we're supposed to do? We're supposed to invade into the information in order to help. So my big mantra now out in the world of education is like, let's have these conversations. Let's get over the fear. Let's not be afraid. And let's help people who are afraid to talk about it.
And so in your practice, is this part of your intake and questionnaire? Or you just kind of like skip all the intake and just start talking about their sex life?
Yeah, we start right there. We cross that boundary and I'm like, I want to know about sex.
Yeah.
No, we don't start there. We don't start
of course.
there.
Yeah.
And I think there's really two great ways to approach it, especially for people that aren't as comfortable in that conversation as I might be. A questionnaire is great, right? Because it opens that door. You're not looking at the patient. They can fill it out. We have a whole section on male and female, like describe your libido. Do you have trouble with morning erections, right? Are you exhibiting hot flashes? I mean, the questions are endless.
Sure.
And when a patient answers that, if you think about it this way from the practitioner standpoint, they're giving you now permission to ask them about it. If it's not on your questionnaire, now it feels invasive, right? Why are they discussing sexual health with me when I came in for diabetes, constipation, right? So the questionnaire is a great of that breaking of the ice kind of thing. And then we elaborate, how is your sexual life? Is it existent? Is it non-existent? Are there any questions or concerns that you have about it? Do you engage? Do you not? Right? And using open-ended questions, I think provides discomfort, but the ability to become comfortable within that. And then we always have the female that drives her husband in that doesn't want to talk to me about his erectile dysfunction, and she does. And same thing, we don't make up names, and sometimes it's appropriate. You got to be careful with jokes, of course, as a professional to a patient. But
sure,
I say that there's this level of like being unprofessionally professional, where you can lighten the room and joke a little bit, where you're not making fun of anybody, but just to provide that comfort. And I'm really good at doing those things too, so that we can laugh and not feel uncomfortable.
So it's like the Dr. Cindy comedic happy hour, but without actually making fun of anybody, just happiness and fun in the room kind of deal. And that's a big thing, I think, as a bedside manner in general for clinicians, right? The idea is to make our patients as comfortable as possible. And oftentimes the best way to do that is some amount of humor, whether it's really terrible humor, if it's dad humor on my case, or if it's Cindy Howard humor, which is probably somewhat related to sexual practice or something. So
I only tell bad jokes. That's what I tell everybody. My poor team at the office, like my assistant who's in the room with me, it's the same jokes over and over and over, and nobody laughs.
Give me top five. Let's give me the top five jokes. Your top five jokes.
Oh God, don't put me. I don't know. They'll come out eventually. That's hard. That's hard.
I know. Sometimes it's like they're very circumstantial, right? Like you're in a particular situation. You have the same way that you describe something, the same joke that you say. I certainly do this all the time when I'm on podcasts, talking to patients and that kind of thing. When it comes to, specifically like diving into pelvic disorders, let's talk about that a little bit, because I think it's not something that's well known for clinicians. Like, what are some of the things that you're like kind of on your radar when you're talking to like men, for example, with pelvic disorders? Like, that's not something that I would think about often.
Yeah. It's interesting. We think about genitourinary disorders a lot, right? Like when it comes to urination, stopping stream, dribbling, pain, blood in the urine, that's all part of the pelvis. That also leads down, the same path as performance, right? So, any erectile dysfunction, fertility issues, another big one in my practice, right? Because usually it's the woman that's going, I have fertility issues, and guess what? Who takes two, right? So sometimes there's fertility issues for men. It could be as simple as low back pain. And sometimes it's pelvic floor dysfunction, it's testicular torsion, it's infection, right? And there's all kinds of different causes for back pain that aren't necessarily mechanical or musculoskeletal. And, we forget about that. What if it's discomfort in a sexual position because you don't have good hip flexor or hamstrings, flexibility and length? And, a lot of this, again, sounds a little crazy, but, if we can improve that, we open up a lot of doors for good, healthy relationships.
Yeah.
On the female side, very commonly too, we deal with a lot of vaginal infections, which get commonly overlooked. We subscribe to a little bit.
Which like the bacterial vaginosis, or which infections are being not seen typically?
You know what, we see a lot of things. I mean, anything from lack of good lactobacillus in the vaginal canal, which, the joke is that the vagina is a self-cleaning machine. We've got the right bacteria up there to take care of the bad guys, maybe literally and figuratively, depending on how you look at that. But, all kinds, from group B beta strep to other staph to E. coli to chlamydia to gonorrhea, right? The whole gamut.
Sure.
And what a lot of women don't realize is we can actually have asymptomatic bacterial infections as well. We don't know what we're supposed to smell like. We don't know what it's supposed to look like. When you grew up, did your mom say, hey, that yellow stuff that's coming out of your vaginal canal, that's not healthy, right? Like, we don't have those conversations. So women walk through their whole life with some of these conditions, but don't know it's abnormal and or that it can be treated and should be treated.
Yeah. Okay. So that's part of the sort of pelvic dysfunction. Are some other things that you kind of think about as well with women?
Yeah. I mean, we've got fibroids, we've got endometriosis, we've got ovarian cysts. I mean, again, all of those different disease pathways where a lot of times we view that as, it's got to be surgery. I don't want my body parts removed. Right. But yet there's all kinds of different great, and I hate the word alternative too, but we use it, right? Alternative to the medical model of surgery, chemo, radiation, things like that, depending on the process. I'll give you a perfect example. So we do a treatment in the office called an escheritic treatment. Escheritic means to burn, and it's not as scary as that sounds. But we see women with cervical dysplasia all the way up from CIN1 to CIN3, CIN4 being full-blown cervical cancer, to where we do a technique where we paint the cervix with bromelain. It's an anti-inflammatory. We clean that off with a calendula solution, and then we apply a zinc chloride with a sanguinaria to the cervix. Sanguinaria is a good old-fashioned Ayurvedic technique that actually destroys cancer cells on contact. And we can actually eliminate all the abnormal cells on the cervix through a series of treatments versus a colposcopy, a LEEP procedure, a hysterectomy. And, again, just that conversation for women who, especially of childbearing age, right, who don't want to lose body parts because they still want to have children, all of these great alternatives that aren't mainstream medicine, but yet have been around for decades and decades and decades to be proven effective. We provide those kind of services in the practice so that they have options, which is great.
That's amazing.
I wouldn't sign up for the colposcopy either.
Yeah. Are there any other alternative procedures that you're doing at the office that are similar to that wouldn't be well known outside of the world that you're in?
Yeah, so the physical of the escheritic treatment is one. We also utilize two other types of therapies. One is a low-level laser, which has a combination of red light, infrared light, and actually blue light, which is really cool. So
it's your favorite color,
right? But it does fight infection. So we can go in with a vaginal glass probe with blue light to actually treat the infection on contact, which is pretty cool. We use it, topically over the abdomen for certain conditions. It can even be used for prostatitis. I mean, really cool. For the prostatitis,
do you insert it up the rectum as well, and then you put it on directly on the prostate?
We do.
What kind of treatment length are you talking about for
4 minutes?
And then you're done, and you come into the office a couple times a week, or what's the typical?
So, we're going to do a series of 6 to 12, right? We're going to recheck the lab markers to see if the inflammation goes down. We're going to repeat the internal exam to make sure that, the prostate palpates as it should, doesn't send anybody to the ceiling. The urinary symptoms go away, right?
Yeah, so prostatitis is a big deal for men.
Markers to determine, how many treatments are necessary. And again, everybody's different.
Yeah, I mean, I'm just going to say that prostatitis is a really big deal for men. It's actually a very common thing as we get older that men will have episodes of chronic prostatitis. Oftentimes, they probably need some sexual health optimization with Dr. Cindy too, which will likely help in this capacity. But that's cool. So the laser is internal, but it can also be used externally as well.
So it's actually an external laser, but there's an attachment of a glass probe so that you can use it with an internal application.
So you use it vaginally as well as rectally?
Too. Mm-hmm.
Anywhere else? Any other orifices, or just those are your major two?
Nasal. So for
Nasal?
sinus infections, works really great to get up into the nasal cavity. We can do it in the ear for ear infections. You got an orifice, we can do it. How's that for a business slogan?
That's a quote. I like that. Okay. So that's your laser. You said you had another type of machine or materials?
Yeah. So there's a great technology called TECAR therapy. It's spelled TECAR. It's enormous in Europe, very big in the physical therapy space, in the aesthetic space, sports teams, enormous over there, very, very common. And there's a handful of companies that are now bringing it to the United States. It's probably been over here, I'm guessing, don't quote me on this, but maybe a good 5-6 years.
Okay.
And we were lucky enough to be introduced to the therapy that we brought into the office. And it's remember diathermy? Are you old enough to remember diathermy? Okay.
No.
Well, we were taught diathermy in school, and it's sort of an old technique, but it's an electrotherapy, if you will. It's capacitative and resistive therapy, and it's all about frequency. So the hertz that you use in order to facilitate change in the body. It increases blood flow. It reduces inflammation, just like a lot of our other great modalities. But what's amazing about it is, depending on the frequency used, it can penetrate all the way down to bone level. And it goes to the cells, which I know are really important for you in the work that you do, to open up the cell to allow nutrients to come in and allow toxins to escape, if you will, from the cell. Okay. So in Europe, they're using it a lot internally. Here in the United States, we're careful with that because the FDA won't approve the actual vaginal probes, and it can still be done manually. But we do a lot of external work over the pelvis, whole body, but pelvis, since we were talking about it, to facilitate some changes. And it was one of those therapies I didn't want to bring in. I didn't want to spend the money. And then when I saw what it did, I wrote the check and I used the therapy because it was just that effective. And we love it. It's and now we're using for aesthetics. I mean, we're getting rid of deep lines and wrinkles and tightening up skin and stimulating collagen and hyaluronic acid. And it's just been a really fun modality in the practice to bring, especially because it's new and it's exciting. Yeah. People haven't seen it yet.
So how does it actually work? Is it like pads, or is it like is it actual like probe types of things, or how is it actually being used?
Yes and yes. Okay. So depending on the equipment you purchase, yes, there's both. What's cool is there's actually equipment too where you can use fascia tools. You can just use your hands and do some trigger point work. And the electricity is generated from the machine through a ground. Just think of electricity through a ground into the human body.
Sure.
And the body responds by generating heat. So there's no heat given out from the unit, but the tissue's warm, and accordingly so we adjust frequency or intensity based on feedback of the patient. And what's cool is the minute you're even done with the treatment is the tissues are still getting affected for hours, if not, a couple days after. So it's kind of a long-lasting treatment versus other things where it's like you feel great for the 20 minutes and then, you're in the car driving home going, yeah, I don't feel so good again.
Have you found some really particular impactful indications? It sounds like a lot of them overall, but have you found anything that's been most impactful using the therapy?
Yeah, it's really cool. So we've now dived into, because I love the autoimmune component of what I do in the practice, is we're figuring out how to be inhibitory or stimulatory over certain organs to get them to behave in a way we want. So we go over the spleen and the liver and the thyroid and upper back, which is in Chinese medicine where wind comes through, where immune system gets affected. We work over the lymphatics to stimulate drainage. And when we know if we want to actually stimulate an organ to work better or inhibit an organ in a way, that's how we adjust certain frequencies, both with the laser and the TECAR. And it's so cool because where the nutrition has been working for me really well, now we're seeing reduction in the antibodies, right, that we use to measure in autoimmune.
Sure.
Faster, quicker, and able to sustain those by using some of these external therapies as well. It's been really fascinating. And I'm at the beginning of this adventure, so, it's fun, but what we're seeing is pretty amazing. And we're just going to run down this path until it doesn't work anymore.
Yeah, until you can find something else that works in combination.
Right.
When you talk about inhibiting versus exciting like an organ, can you give me just an example of what you would mean? Because I'm just thinking about what would you want to inhibit in somebody like as you're using the therapy? Just interested to know.
Right. So like, for example, we might want to stimulate the thyroid to work a little bit better, right? It's underproducing in terms. Coupled with that would also be pituitary. So sometimes we can go into the noise. We can go into there's a lot of noise and disease. We can go into the nose with that laser with the probe and point it in the direction of the pituitary in order to be stimulatory to get that pituitary to signal to the thyroid better.
Sure.
But at the same time, let's say we're having like a massive histamine reaction in the blood cells. We're getting rashes, bumps, etc. And we might want to say to the spleen, hey, knock it off. Don't have this kind of reaction. So we might want to use a different frequency to go over the spleen to say, hey, stop, calm down, right? Behave yourself so that we don't trigger that type of reaction in a human being that might be exposed to something to generate an external, rash.
Makes a lot of sense.
Bumps, whatnot. It's pretty common. And sometimes we get it wrong. Sometimes we think we need to stimulate and then the patient gets worse and then we learn, maybe it should have been inhibitory. And you know this, right? Like from all the neurotransmitter work, that sometimes, right, we need to actually inhibit when we should have not stimulated.
And you don't know sometimes until you have that practice and you try. And then there's such like individual variation here too. That's the challenge, right? So you can have one person work one way. And then this is what I love to hate about influencers on all our social media channels that don't see patients, right? I don't know do you have a high horse like me about this? And all these people that are going out there telling people all this advice about nutrition and lifestyle and supplements they should take, but they don't actually see patients for a living.
Yeah. And it's hard, right? Because you want to spread the wealth of education and knowledge to get people to start to think about it, right? So to your point, it's a good, bad thing, right? Because I love when patients walk in the door. You know what's funny about this? Is I can always tell what's trending on TikTok because there'll be a week that goes by that I get the same question.
Interesting.
The exact same question, right? Like, what do you think about chlorella? And I'm like, oh, you watched TikTok last week because there were a couple people talking about chlorella, right?
That's so interesting. Yeah.
And I love that because even though they might not be getting great information, at least if they then ask me the question, I can say, I know, I don't know, I'll find out. Here's my thoughts, and then they get hopefully a little bit more direction to make a better choice. So I think it's good that it's out there, but I agree with you. We've got to take some of that with a grain of salt. It's like Dr. Google, right? I always tell my patients, I'm like, when I give you all this information and you're done asking Dr. Google what you should do, come back and then vet that information for me and I'll tell you if I agree with Dr. Google or not.
Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision dose, physician formulated, and pharmaceutical grade formulas in the form of a buccal troche. For this episode, check out our Trommune. Trommune is high strength, high potency cordyceps from the cordyceps mushroom, but 100 times more potent as an anti-infective, as an immune system support, as an anti-inflammatory. It is the winter. You are going to get sick if you're not careful. There's a lot of stuff around no matter what you do. Trommune can help you. You can take it prophylactically to prevent yourself from getting sick. If you're around a lot of people that are getting sick, take some Trommune. Go to Transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. Yeah, it's a dangerous place, the Dr. Google doldrums, the danger, the death spiral that can happen if you go there. Like, oh, I have a hangnail. Oh, you're going to be dead in 6 months or something like that, right? I have a cousin. She may listen to this podcast. I don't know, but she's kind of like that, where that she hears about one thing and then everything just kind of goes down this rabbit hole. I think it's just a challenge for us as educators, Cindy, because you and I we're seeing patients. We see how heterogeneous the reactions to things are, to various therapies, to various supplements. People can have paradoxical kinds of things. And like, it's like giving your kid Benadryl before you go on an airplane. Not a good idea if you've never done it before. You could have the opposite reaction, right? And so I worry about education to the consumer because we have all these researchers, these PhDs and others that like they're doing good research, most likely, but they're talking about their own protocols and how they're doing things. And then that's not necessarily going to be the most effective for you or for the person that's listening to that podcast, right?
And I think that's the challenge in medicine, right? Because I know when I was a little younger in practice, I used to have students come in and shadow all the time, and they'd be like, "So, Dr. Cindy, why did you do that?" And I'll be like, "I don't know. It was just the mood I was in." Like there's an instinct sometimes in medicine too that points you to a certain direction, because if we follow the textbook answer of everything that we're supposed to do, we're going to get a small percentage of the patients well, and then a large percent not well. Right? Because we didn't navigate those different individual needs. But I will say, it's funny. You said about the hangnail, and I went down this rabbit hole, and I'm like, but if you pull the skin off hard enough, and now it's an open wound, and then it gets infected, and then you get septic, and then you wind up in the hospital, and then you pick up C. diff, and you can't fight the C. diff because you had diabetes that nobody diagnosed, you actually will die from a hangnail.
It's certainly possible. It's very low on the list, but it's definitely possible that you may die if you go down that rabbit hole, right? So, and that's the thing, like you can hear all these stories about this person that had a hangnail that died, right? And so But it's just not common, not common,
Right.
guys, right? So when I listen to this stuff and I just go, I'm just happy there's people like you that are out educating to try to get people to have information that is clinically relevant, because you see people in clinical practice. You know that it's not easy to see people. It can be very difficult. And one thing I want to ask you about in all that capacity is, like, I know you use a lot of supplements in the office, right? Do you think that supplements are always necessary, or do you think that we can get most people off of supplements? They can do it all through diet and nutrition? Or like, what's your sense here? I mean, I know what mine is, but I was wondering what yours is.
You know what? I love your questions because my answers are always yes, yes, and yes with all the options that you give
Of course.
me, right?
Yeah, yeah.
So theoretically, if we could eat perfect, I wouldn't have a practice. I believe that,
sure.
right?
Yeah.
Like, and I joke then I'd have to go get a job managing a McDonald's, but if we ate perfectly, McDonald's wouldn't exist. Sorry if anybody owns a McDonald's. I know they generate a lot of income, but we're supposed to get, right, on that cellular level, all of the nutrients from our food. That's how we're designed, right? We get our carbs, our fats, our proteins. We're supposed to get all of our nutrients that those cells need, and not any of the garbage that we're eating and we're breathing. The reason I'm going to answer the question, yes, we need supplementation a lot, not always, a lot of the time, is because A, we're not getting that.
Right.
B, even if our food isn't always nutrient dense. And C, there's still other junk that we're exposed to that could alter what our cells are doing as a result of good nutrients, right? There's pathway issues where even if we get the nutrients, we don't know that we have the correct analytes to move the nutrient down the pathway to convert or methylate or do whatever it's supposed to do, right, to get that outcome. So I love the idea of supplementation. What's funny about that is everybody goes, oh, you do all natural supplements. Well, not really, because if you think about it, I don't walk outside into my front yard of my practice and pull a bottle of vitamin D off the tree.
Right.
Right? It's still in a bottle or a package or something. It is still manufactured to a certain degree. Is it safer, in my opinion? Absolutely. Is it still more toward the natural? Yes. But vitamin C in a tablet is still very different, right, than the orange that you pulled off a tree that had good soil without pesticides. So I do love supplementation. However, I will never hesitate to throw people on as much as I think I need to facilitate the change, with the goal to get them off everything I absolutely can, if I can, to nothing or, a couple baseline things. So if you need it, we do it. But I don't ever want people to think they're going to walk in my office, be on 50 bottles of pills for the rest of their life, because if that's the case, then I actually didn't solve their problem in a way that was beneficial. And now I really know better than here's the whatever it is to mask the symptoms. Good luck and see you in 10 years.
Yeah, no, I'm 100% with you. I think that, nutrient density is a big part of it, right? But it's like even the food now, eating healthy, organic, artisan, the cow was petted and massaged every day the rest of its life. Like the amount of nutrients you get is going to be about 50% less than it was about 50 to 70 years ago. This is for our plants. This is for our animals. Although we know that animal foods tend to have higher bioavailability. So I always tell my patients that, look, we're living in a synthetic world. We're living in a nutrient depleted world. It's sometimes necessary to have synthetic things and to have nutrient dense supplements because you cannot get it from the foods that you're getting. It's something that I have a conversation with a lot of my patients about too. Like oftentimes we start off with a lot of supplements and over time, we hope that we can come down on them over time. Do you find like there's like a foundational supplement, like a number of supplements that you use in practice that almost everybody gets? Or is it very, very variable depending on the patient?
So if you come in and you let me run laboratory tests to determine what your needs are, completely variable. Somebody will walk out with one and somebody will walk out with,
a lot
more than a couple handfuls. I don't want to scare anybody.
Yeah.
If you come in just saying, hey, I'm not going to spend any money and I'm not going to do any tests, can you make some recommendations? Not my favorite approach, but I will. Multivitamin. It's therapeutically not going to solve a single thing, but if you're not going to let me test to see what you're deficient in, it might fill in a little bit of gaps if you're not eating well. So then I go the multivitamin route. If we test, I almost never put people on a multivitamin.
Right.
2 is vitamin D. I find that most people are just vitamin D deficient. Now, how much? Again, I don't know if I don't run the test, but we can be pretty safe with, a couple thousand, 4,000 IUs typically, and see what happens, right? So I love vitamin D because I could probably dig out 1,000 patients and find only 1 or 2 that I didn't think needed supplementation. So
Sure.
Not that I want to get it wrong, but 1 or 2 out of 1,000 is pretty good odds.
Yeah.
3 is I love fatty acids. I love omegas. So I find that most people don't get enough of that in their diet. So a good EPA, DHA, DPA supplement with a little bit of GLA, which most people are not getting with their fish oils because the gamma-linolenic acid is very protective. So that when you take it long-term, it doesn't become pro-inflammatory instead of anti-inflammatory.
Yes, that's a good point. Most people don't know that. Yeah,
and most people don't know that. It's kind of, I always say it's the nutrition dirty secret that nobody knows. Yeah. And then the fourth one I would say is probably a good probiotic. However, I'm slowly changing my mind about that recommendation because the more we learn about the strains and what they do, we understand that the diversity in the gut is not a good thing, right? And I always talk about probiotics as two kids sitting on a teeter-totter. Remember the teeter-totter or seesaw on the playground?
Yep.
Remember those? And if you think about it in a way of you've got a very heavy kid and you've got a very skinny kid, and they both sit on the ends of the teeter-totter. They're both great kids and they should be playing together on the playground. They're not going anywhere, right? Because the weight isn't equal. Well, in the gut, when we start to look at the microbiome and the level of probiotics, good bacteria, commensals that belong in there, we're finding a lot of dysfunction. So they're all good, but we don't have enough of this and we have too much of that. And there's no teeter-totter happening. So when you say, should I take a probiotic? Which one should I take? I don't have any idea, right? Because there's 27 million strains and do I take 1 billion or 62 billion and does it have to be refrigerated? And we now know with some stool function study tests that we do in the office, we can actually look at a lot of those commensals to get those answers, which is great. But one of the challenges I have is I still don't have the ability to compound the exact good bacteria balance for people in a way to say, this is exactly what you need, go get it. So we get close and we're working on that. And I think 20 years from now, we'll have some compounded probiotics. But that's where that one I'm a little more careful with too, because sometimes we can create more imbalance unintentionally. And, then I make people worse.
Yeah, no, I've actually had the same experience, interestingly enough, because I work with people that had a lot of brain injury, for example. And they come in, they have a brain injury. I want to put them on a whole battery of things before I even know what's going on, just to help support their brain. And I used to put them a lot on the live probiotic strains, but I've actually transitioned over to do more of the spores because I find that that's a little bit more supportive and I don't have as many issues with them over time. I don't know if you've tried the spores, but that's been helpful for me.
Absolutely. But still same thing, right? Yeah. So, and how many do you give then?
Right. You just don't know, right? You don't know. So when you're doing the stool, when you're doing stool analysis and you're looking at actually their commensals, their potentially pathogenic bacteria, what's your usual framework for using probiotics, prebiotics, postbiotics? Do you do all those things together? Do you have a specific framework that you use? It just, again, depending on the patient, I'm sure, but do you have various categories that you think about when you're using the testing to help guide you?
The prebiotics come into play for me depending on the level of short chain fatty acids. So if we're deficient in, butyric acid or valerate or one of those, then I like the prebiotics from the fiber component.
Yeah,
a lot better, right? Where I might couple. So if they're really deficient there, then I'm gonna double team that a lot heavier. The one area I'm actually really careful, and this is a great sort of clinical pearl red flag, is anytime you put a patient on a probiotic and they get worse, please believe them. And that's really a red flag for SIBO, or the overgrowth of bacteria in the small intestine. Because sometimes when we get the bacteria to the small intestine and it doesn't migrate down where it's supposed to be, now we get the production of methane and hydrogen gas as a result of a carbohydrate or sugar intake, and we actually make the patient worse, right? So if we're dealing with a potential SIBO, a lot of times, even if they're deficient in the commensals in the large intestine, I will hold off until we fix all the other components, then go at them with the probiotic. If I don't think that's a concern or they do well on it, then I hit it along with it, add in the prebiotic, the inulins, the apopectin, arabinogalactans, all that fun stuff, especially if the short chain fatty acids are deficient.
Yeah, I think it's such an individualized process, right? And I think you said as well, it's still in the infancy in the sense that you want to give certain strains and not others, and then it's not really possible yet. But I think a combination of the probiotics along with the postbiotics, like your butyrates, for example, can be very, very helpful. I also use a lot of the phytoceuticals like your berberines and oil of oreganos and those kinds of things, which tend to be very, very helpful. Although they can cause, pooping out the screen door kinds of diarrhea if you're not careful. That's the Southern expression that one of my patients told me once. He's like, doc, I was shitting out the screen door with that stuff. And I was like, that's fantastic. I'm going to use that every once in a while when I'm on a podcast or talking. I'm sure you've had that experience.
You know what? Then you just got to give them a little charcoal and clay to bind so that it's black and it scares people when it comes out. Good Halloween trick, That's
a good Halloween trick as it's coming up. Yeah. So Sadie, I know that you have a clinical practice. You're you're in the weeds, you're doing this, but you're also trying to do, like the way I met you is like, you've been educating for a long time in multiple different realms. Like, where do you think, like, as you're educating, as you're doing this and you're talking to so many people, like, where is the interest in the work that you're doing, like, most resonating? Or what are you talking about now that seems to be like the most resonating to other clinicians that you've been speaking about? Because you're doing this all the time.
I am. Yeah, I run around the country educating, doctors and now trying to get out into the lay public a little bit more. But I
Yeah.
think it's really about just exposure of all these different areas within, again, that internal medicine nutrition realm for people
Right.
to understand that we have to stop pigeonholing medicine, right? We've become such uber specialists in these little tiny things, which sometimes is necessary, that we don't look at this entire big picture, right? And it needs to
Mm.
be seen. And I'm a big advocate of building a network and referral because, like, even as broad as I practice, I am not an expert in everything, right? Like, I have my gifts, but I have some really brilliant people in my toolbox that I refer to who do things differently, better, and bigger than I do. And I want to encourage physicians to do that, right? Like, we've got to
Mm.
stop being afraid of losing patients or being the only one to take care of them, because there's plenty to go around. And
Right.
sometimes I'm actually more brilliant because I got you into somebody else's office than even my own. And that's still a success story, right? Even if it's not by my hand.
I 100% agree. I think it's really important to know what you don't know, or at least if you don't think you know it as much as and you have a friend or a colleague that can help you, like, that's what you leverage. And I think people really, patients especially, really do appreciate when you're able to refer them to somebody when you say, you know what, this is not something that I personally as specialized in as this colleague of mine that I can send you to. So I know you do a lot of like the CME, like the CEU stuff for doctors and practitioners. What's your favorite stuff to do? What's your favorite things to talk about overall, would you say?
Oh, I love poop.
Ah,
Love to talk about poop. That's another taboo subject, right? Like, everybody poops. We all have gas. Nobody wants to talk about it. It's amazing how many people don't even look at it, and it's been around long. Like, everybody knows now. You have to be living under a rock to understand that, your poop can tell you a lot about your health, but yet it's still a weird thing. And like, we can't get through dinner. Like, you come have dinner with me, we're going to talk about poop.
while you're
Same
eating, of course, right?
same
Yeah.
thing. You sprain your toe, I'm going to ask you about your bowel habits. I want to know how often you go. We had a girl in the practice, I kid you not, I can't make this up. We had a girl who came into the practice, did not have a bowel movement for 31 days. No tumor, no blockage, no anatomical reason. 31 days did not move bowels. I was freaking,
Why?
right?
Why?
Well, yeah, exactly.
Yeah.
You know,
I mean, how?
lots
Both
of
of those
whys,
things.
right?
Yeah.
Lots of diet, lots of stress, actually a
Wow.
lot of
That's,
emotional component to that too for
I'm
her.
sure. I'm
Lots of
sure.
emotional.
Wow.
But,
Yeah.
people walk in thinking moving bowels, twice a week is fine because it's their normal.
Yeah. It's what's normal for them. Yeah.
Oh, you know
Yeah.
what else? Okay, you're going to love this. And I'm sure you know this, right? But for a couple of people out there who might not, how many years ago? 25 years ago, long time, I was in China. And in China, and hopefully it's changed, but in China, when you use a public washroom, which is scary because they're troughs, right? Okay. So they're troughs that you have a bowel movement over. They gave me 1 square of single ply toilet paper.
One
That was
square.
it. Now,
Yeah.
I don't know too many Americans that can get away with 1 square of single ply toilet paper. So when I educate on poop, and it is true, when you have a great bowel movement, you really should only need that 1 square to confirm that you didn't need it in the first place.
Ah, gotcha.
There should be no
Quick,
residue,
clean,
right? So people who are wiping
yeah.
and wiping and funding, the toilet paper companies, we're
Yeah.
getting it wrong. And people freak out. And sometimes I'll even walk into the presentations with that 1 square of single ply toilet paper to give to everybody and let them know they've got to get through their whole day only using that. And when they can do that, they pass the Dr. Cindy, poop test of good, healthy bowels.
I love that. That's a great little, you just throw it up in the air. This is it. This is all you guys get for the day. Can you do it? Right? Yeah.
Really?
I
And you
love that.
shouldn't even need it. It should come out clean.
That's amazing. I love that. And I know you're doing more speaking now to the lay audience, like you said as well, Cindy. And I know you have a book as well. And I'd love to just to kind of maybe finish off talking a little bit about your book, a little bit about your story, and how that has obviously colored everything that we've been discussing today, just for those that are listening. So give us a little bit of a rundown of your crazy, harrowing, amazing adventures in brief, and we can talk about it for a minute.
A little over 10 years ago, actually, it was December 2013. I woke up one day with a giant-sized golf ball sticking out of my neck that I was smart enough to know was a lymph node. And I waited a few days and I never got sick, which is weird because you shouldn't have a giant sized golf ball sticking out of your neck if something isn't wrong. Well, something was terribly wrong. And you fast forward through my self-diagnosis of Hodgkin's lymphoma, which is what I was walking through. And it's a little weird to diagnose yourself. And I got the news in between two patients. So, talk about having to process and move on, because when you're in the room with a patient, it's never about you, it's about them.
Right.
And as a result of that, I made a decision that I was going to go to Germany and get care. And I picked up the phone to a very dear friend, Dr. Michael Taylor, who's out in Oklahoma, who I trust with my life. And I said, okay, I've got somebody to cover the practice, somebody to watch my kids. I'm going to get on a plane to Germany and go to the Clinic St. George over there because they treat patients with cancer very differently. I don't want care in this country. Not doing it. And he goes, you're staying here and you're going to get chemotherapy and you got 3 little kids you got to raise and you're going to live. And I went, you're nuts, not doing it. Because I'm not a fan of chemotherapy, right?
Right.
Poison, like they kill you while they keep you alive kind of mantra. Well, I came to learn that, there is a time and a place for everything, whether you believe it or not. And Hodgkin's lymphoma is 85%, give or take a percentage or two, curable, not remission, curable with chemotherapy. So I decided, okay, I'm going to listen to Mike. I came to peace with it. Again, kind of a big, long story, and just buy the book and read it and you'll hear the whole thing. But I also decided I was going to clean up the mess that they created in my terrain. So about 150 pills of supplements a day, IV vitamin C day before, day of, day after, hyperbaric oxygen therapy, on and on and on and on and on. And 10 years later, I'm here to tell the story. During that process, I'm a big fan of journaling. I really love to just think and write. So I kept a diary, if you will, the entire 6 months that I went through treatment. And when I was done with it, I thought, it's pretty great, right? It was very transparent, very raw, and very honest.
Sure,
and
I'm sure. Yeah.
I thought, I've always wanted to write a book, so I'm going to write a book. And then I put it away for a lot of years because it was very raw and transparent and hard and emotional. And many years later, and it's interesting because sometimes when I still do my keynote speeches, I have tears in my eyes when I talk about my story. It's now enough removed that I could put it out to the public. So I took the chapters and hired a ghostwriter, not to write the content, but to organize it and make it legible. Because again, doctor, write messy, right? Can't even write a book neatly. To organize it in something I'm very, very proud of. And it's called Positively Altered, Finding Happiness at the Bottom of the Chemo Bag. So what was interesting is I had 2 pretty interesting things happen to me as a result of it. One is I had to come to a comfort level of doing something I didn't think I would do. Right? I had to be okay with that choice because it was my choice. And it was very difficult. And I forgave myself for that. Right? I had a peace with that. 2, I learned that I can get sucked into this whole cancer word of being a victim and it sucks and it's miserable and why me and all of that crap. Or I could experience and walk through it and find the gifts and the joy and the laughter and the happiness. And 90+% of the time I found that route. And there were moments that, yes, I laid on my shower floor crying, going, really, what did I do to deserve this?
I'm sure.
Right.
Yeah.
And it's not about deserving it. It's about, and I really wholeheartedly believe this, I needed it. I needed it to learn some life lessons. And there were some things that I needed to pay attention to and grow from, which is why I was faced with such a big challenge, because I've had tons of challenges in my life that other people would say were horrible. And I never learned my lesson from them. And this was a good one. So now I love to run around and, besides the CE type stuff, do more of that keynote, 50 minutes of let me stand on stage and talk to you about why maybe wearing your thong underwear backward and leaving it that way on accident because you got chemo brain is not a horrible thing. And we can change the power of the words to make them good and fun and not scary and dangerous, still understanding that things are serious and they need to be addressed. And really just how to overcome adversity, because we're all going to have it. Like, open your arms, because as you always say, the shit's coming, right? The shit's going to hit the fan. It's coming one way or another. Divorce, illness, death, whatever. And let's get through it and let's enjoy the ride.
Yeah.
And that's my message. And it's cliche, but if it changes one person's outlook to do things a little bit better, then I'm really glad I wrote the book and you learned some things about me that are raw and transparent.
Yeah, well, that's you, Cindy, in a nutshell, right? Well, I appreciate your time today. This has been really awesome. I have one question for you at the end of the podcast that I didn't warn you about, because you didn't warn me about the questions at your podcast either.
True.
The name of the podcast is called Smarter, Not Harder. So we ask all of our guests at the end of the podcast, what are the 3 ways that anybody can live smarter, not harder, in your estimation?
I love it. So live smarter. 1, learn to forgive yourself. So whatever you do, even if it's a mistake, learn from it, move forward, and just forgive. I say one regret in my entire life, and that's probably not even true because I just don't look at things that way. And I would love for people to just say, made a choice, did it, didn't work out, and move forward. So forgive yourself, number 1.
Love it.
Number 2, please balance, right? Like, I'm a workaholic. I love what I do. I'm working all the time, but I take time for myself every day. I take time for my family. I take time to vacation. You know, one thing I learned, my oldest daughter was born to me 10 and a half weeks early, 2.5 pounds, story for another day. But I spent 6 weeks in the NICU, not paying a bill, not returning a phone call, not paying attention to anything other than her little life, and the world didn't fall apart. So at the end of the day, the world is not going to fall apart, even though we might think it's going to.
Sure. Yeah.
So put the work down, and honor yourself and your family and your friends every single day in some capacity, because that's what's important. The work supports those things, right?
Yeah, that's beautiful. Yeah.
So that's number 2. Number 3, can you just breathe? Just breathe. We breathe because we have to, right? Because you're dead without breathing. But just breathe with intention and take those deep cleansing breaths throughout your day and throughout your life, because everything just functions better. The brain works better. The organs work better. The stress goes down. And that big giant sigh that you can initiate through breath actually can really change your outlook in your life. So forgive yourself, take the time, and just breathe.
Universal truths that are amazing. Thank you for sharing, Cindy. Where can people find more about you, what you're doing in this beautiful world and your ecosystem?
Love it. So if you want to find more, check out drscindyspeaks.com. You can sign up for my community newsletter. We don't bombard you every day. It's a once in a while. We try to just give you some good stuff to think about. You can find me on all social media platforms at Dr. Cindy Speaks. Let's see, that's LinkedIn, Facebook, Instagram, and oh my gosh, I'm even on TikTok now, much to my dismay, but it's where everybody's finding their information. And if you want to reach out, my email is hello@drscindyspeaks.com. That's all book related, all speaking related. The book is Positively Altered: Finding Happiness at the Bottom of the Chemo Bag, Amazon or where books are sold. If you can't find it, just call me. I'll probably send you one. Okay, don't call me. I can't mail out that many books. That's too many books. And if you want to reach out,
you can find her at a conference. She'll have books
at a conference. I will have them and I will sign them. And then for my business, it's Innovative Health and Wellness Center. It's innovativehwc.com or 708-479-0020. Any way I can help, reach out. That's what I'm here for. It's what I love. It's what jazzes me. Yeah. Scott, thank you. This has been an absolute gift, and I'm very appreciative of the time today.
It's been awesome. Well, everybody, thanks for listening. We'll see you next time on the Smarter Not Harder podcast. Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. Today was a fantastic episode to record with Dr. Cindy Howard. We talked about her personal story. We talked about her medical practice, about being a chiropractic internist, and everything in between. If you like this podcast, don't forget to like and subscribe below, share with your friends, family, and colleagues. And we can't wait to see you on another episode coming out soon.